I'll give you just a few thoughts about it. Everywhere I go, people ask about what's the standard of care. And I talked a little bit about this in the course that I did with Bhavna, but I made my slides shorter just to come to key points. So what are the challenges? Why retinoblastoma can be so difficult to grasp? Of course, because of rare disease, and there's threat to vision, and risk of tumor dissemination, mortality, and of course long-term sequelae that can happen. Just to keep in mind that radiation therapy was discontinued after 30 years of use. It took 30 years to find out that it was a bad thing to use. Of course, there were no alternatives at that time when it was started. So think about that. It may take 30 years before we find that some of the newer therapies may have complications. That's something to keep in mind. So I'll just continue. So obviously you cannot treat retinoblastoma just by being in an eye hospital. It's a multidisciplinary treatment. As you realize, it has to be in a specialized center. You need tremendous social support. We know that without this, you're not going to have good outcomes. That's a given. So I thought about it from the previous talk, and I've come down to like 12 minimum standards. Number one, you really should be able to suspect the diagnosis. You cannot make diagnosis of retinoblastoma if you don't suspect it. It's a child with hyphema, endophthalmitis, you drain it or tap it, whatever, you did not suspect, you'll never diagnose. So that's number one. And number two, you should be able to diagnose without biopsy. And it came up in discussion. Almost always, you should be able to make a diagnosis. And if you cannot, please just send it to the right place. Okay, that's, I think, is very important. Most of you realize that. Third is that you should be able to stage the disease. Is it group or stage the disease A, B, C, D, E. We typically use the international classification system, which itself is going some modification. But nevertheless, you need to be familiar with the grouping of the tumors, because the treatment actually depends upon the grouping. So you'll be able to individualize the therapy. So group A retinoblastoma is wholly different from group E disease. So they're not all the same. Okay. So if anybody disagrees, please come up later on and put the view forward. So, and I think if you're treating retinoblastoma, you should be able to offer them local methods of therapy, thermotherapy, cryotherapy, plaque therapy, and of course be able to perform enucleation, which is not just removal of the eye, but also to look for high-risk factors, to look for adjuvant therapy, maybe perhaps obtain tumor sample for potential genetic testing, and be able to restore cosmesis. There was talk about it. There's no reason not to put an implant, and these are the two children. Each one has had one eye removed, and they look beautiful. So you should be able to restore cosmesis. And if you cannot do this, don't do enucleation, send them somewhere else. Okay? That's my point. Be able to deliver chemotherapy. The treatment of retinoblastoma has come down to chemotherapy and how you deliver. You should have practically most of these treatments available. Okay, intraarterial may be challenging, but at least the others. And you should be able to know what to use when. So this is, I think, the number 7 standard. And of course, the whole idea is to not radiate, because we realize it causes tremendous complications. Perhaps enucleation, I would say, is anytime better in germline disease than subjecting the child to radiation. And then, of course, we talk about personalized care. Okay, you look at the baby, look at the family, all the support, and it's a long-term commitment. They're little and they become older, and you continue to follow them because they can have later recurrences and late complications. And of course, continued education. You need to keep learning new things. Some of the treatments that I'm talking about were not there when I was a fellow. I was a fellow 25 years ago. There was no intraarterial. There was no intravenous chemotherapy. It started in 1996 after my fellowship. So all the treatments we talk about happened after I finished my training. So how do you keep up with it? You keep educating yourself. And of course, I think most important really is to look at your own data, look at your own outcomes. If you don't do that, you don't know what you're doing. And I think that's an absolute standard. You have to report outcomes. You don't have to publish them necessarily, but have them even in internal audits, Indian Journal of Ophthalmology, ICMR, somewhere along the line. I think you have to report outcomes, at least for your own satisfaction, that I'm able to know what's happening to your patients. How do you know what you're doing is the right thing? You don't know. So I'm coming down to this outcomes, and that takes us to the next part of my talk, the next 5 minutes. We say we do a national retinoblastoma study. The purpose is to improve outcomes eventually by collecting data. If you don't have data, you don't know what the survival is, you don't know what the control rates are. And how do you collect data? Obviously, it's a collective effort as a study, which is, of course, prospective. It has to be inclusive, it has to be collective, it has to be prospective. Retrospective data, as you know, is flawed in many, many, many ways. So there's no reason why people from top institutions here in India cannot do a prospective study. If you cannot do it, there's no one else who can do it. So it's not the question why you have to do it. The question is you do it because you can. And that's the way I think you want to think about it. One other slide here. What happened? Okay, so we're talking about, in different phases you have to go. Obviously, you can't do everything the first time you start with registration, standardizing treatment, perhaps optimize it. Different hospitals do it differently. But time will come when you're able to compare them, maybe eventually reach some kind of randomized trials. And of course, then you continue. The fact that you are reporting your outcome itself improves your quality, because you're opening your data or your outcomes to someone else to look at. We at Cleveland Clinic have to report outcomes for many diseases, and it's online. Patients can see the risk of dying from heart disease, for cardiac bypass, for example. They can see the mortality. It's all published. So it's an inherent thing. It's an important for outcomes. The fact that you report outcomes itself improves quality. That's well shown everywhere. And of course, we're talking about data. If you have data, you can go to CanKids, you can go to ICSHA Foundation, you can go to different foundations, say, look, our survival is 50%, we want to make it better, I want to do this, and then show that it's better. Then you can show how you use their money. If you don't have the outcomes before and after, how do you know that their money, the lakhs and lakhs of rupees that they're spending, is actually taking you somewhere? So you really have to have data. And of course, you put in some questions and improves the patient care. You talk about all the improvements and all the innovations that can happen in all this process. You can test different cameras, different methods of storing tissue, different genetic testing. So yesterday I flew to Bangalore and I had lunch with these nice people, 2 people from ICSHA Foundation and Dr. Mittal here from CanKids. I just went only for fundraising. I'm trying to convince them to support us. I know there are other efforts going on. They're all complementary. I'm interested in producing high quality data. And how you can do that? It will be Brenda Galley will be showing. She has a database that she can use. It's all structured and she'll talk more about it. So we have a high quality database, and garbage in, garbage out in data. It's the quality of data that matters. Somebody has to vouch for the data, and then you can use it in the future. If you don't have good data, whatever you do 5 years later is meaningless. So I'm going to stop there and give time for other people to speak, and Brenda will add on to this data. I mean, it has to be entered some way and collected a certain way. And we'll come back to that, Brenda, later this morning in part of the talks. So thank you very much. And